10 minutes because its efficacy is proved to be as much as that of the conventional C3R. And the limited evidence regarding the long-term outcomes of accelerated C3R is another drawback. The maximum follow-up which has been done till now is only up to 10 years. And in accelerated C3R, once the time comes down, the oxygen gets depleted faster. So that's why it leads to the efficacy is not as comparable as that of the conventional C3R. So there comes the role of pulsing approach, wherein we are giving time for the oxygen to replenish in between. So it's a 1 second on and 1 second off protocol as compared to the continuous UV radiation. So the only drawback in this approach is that we are not giving, the studies have not given the exact duration for which the pulsing has to be continued to get a reasonable outcome in the C3R. Next comes C3R in thinner corneas. Dresden devices standard protocol for corneas more than 400 microns thickness. So beyond that, that is beneath 400 microns, there are various modifications which have been used, including the Hafizi's hypotonic riboflavin. However, the drawback with hypotonic riboflavin is that the swelling effect is variable with different corneas with different thickness. So the effect of C3R is accordingly variable. And there comes the epithelial on approach, that is a transepithelial approach using permeability enhancers. Here again, the actual CXL effect is questionable, even though the patient comfort is enhanced and the risk of infectious keratitis is low. And the other modifications are iontophoresis assisted C3R, lenticule assisted C3R, and contact lens assisted C3R. All of these are transepithelial and better tolerated. The only problem is long-term studies are not available. And epithelial island cross-linking is a modification which was given by Masota. It's basically a partial epi-on and an epi-off approach, wherein epithelial cells are left on the top of that is on the thinnest part of the cornea. And the most frequently used and universally accepted one is a sub 400 protocol, which is given by Hafizi, which can be used successfully in corneas as thin as 214 microns. So this is a nomogram which was given by Hafizi, wherein according to the thickness we can titrate the time for which UV radiation has to be done. A similar protocol was given by Masota, but the only difference from that of the Hafizi is that it requires multiple sophisticated technologies, including iontophoresis, depending upon the thickness of the cornea. That's why it's not practically that accepted. So next one is the next UVA calculator, which was given by Shetty et al. The calculation is based more or less similar to that of given by Hafizi. Here you just have to put in the minimum corneal thickness and you will get the time for which UV radiation has to be done. Next is CXL plus procedures, wherein we combine C3R along with refractive surgeries. Whether it should be done two-stage or single stage. Single stage is preferred because second step PRK removes a part of the cross-linked tissue as well, and the risk of haze is higher, and refractive results are also unpredictable. So we have various protocols in CXL plus procedures, like PRK can be combined with C3R, which is the Athens protocol, which was studied by Kimernis, and the results have been sustained for a period of 3 years. Similarly, Critten's protocol, various studies have been done, like Shetty et al.'s TREC and TGPRK. The tissue removed in TGPRK is maximum can be removed up to 50 microns, while in TREC up to 25 microns. And you can also compare intracorneal ring segments with C3R. The only thing is that C3R should be delayed. Extra procedures are the ones which are followed in LASIK, SMILE and PRK. After the procedure, C3R can be done. The total energy delivered is 2.7 joules per centimeter square. That is 90 seconds of soaking and 90 seconds of UV radiation. Now, this is the era of customized C3R, wherein you are just using a method to improve the corneal irregularities. At the same time, you can also enhance the visual acuity. So, the PACE, which is given by Hafizi, is the latest customized C3R, which is PTK assisted customized epithelium on C3R, wherein there are 3 requisites. One is epithelial map driven PTK and a gradient of riboflavin concentration, which is peaking on the cone, and area of the cone receives higher total fluence compared to the rest of the cone. And it has been shown to regularize up to 12 diopters and improves the corrected distance visual acuity, and later on a touch-up PRK can be done and is used in stable keratoconus. And complications, as we all know, C3R comes with its complications, which is associated with UV, epithelial debridement and corneal flattening, which can be corneal haze and opacification, infectious keratitis, persistent epithelial defects, stromal melts, hyperopic shift, endothelial damage and associated decompensation. C3R failure, it is termed as 1 diopter or more steepening of Kmax or an increase of 1 diopter or more in the manifest cylinder over the past 6 months. Risk factors include Kmax more than 58 diopters, patient 35 years or older, female patients with weak AC, corneal thickness less than 400 microns, and those with eccentric cones. So this is the future directions which are under study, which include stem cell therapies, advanced cross-linking techniques with a better safety profile, tissue engineering, nanotechnology applications, and even personalized medicine approaches are also underway for better treatment in future. So yeah, thank you.
Thank you for that lovely talk, Dr. Veena. So now that we have known how to stabilize keratoconus, we'll be moving into visual rehabilitation in keratoconus. The first and foremost important part in management is contact lenses. So we have Dr. Anita ma'am who's going to speak about contact lens fitting in case of patients who are not comfortable with glasses for keratoconus.
So good morning. First of all, I thank Sanjana for that generous intro and for giving me this opportunity. And so, myself, Dr. Anita. Today, I'll be speaking on fitting the future. Fitting the future with advancements in contact lenses for optimal keratoconus vision. So, keratoconus is one area where technology has rapidly transformed patient experience. And today we will look how we can use the modern technology wise contact lenses to give your patients the best possible vision and comfort. So contact lenses, is it still matter? Yes, because as the corneal irregularity increases, spectacles simply fail to provide good visual acuity. So even in this era, in 2025, the contact lenses remain the cornerstone for keratoconus management. And our goal is to give maximum visual acuity to the patient and comfort while maintaining corneal health for longer period. So we now have a spectrum of lens options customized to disease stage and the patient comfort. Of course, your RGP and the rose scale lenses are the best optics which you can give to the patient for mild to moderate cases, and they are still the gold standard in mild to moderate cases due to their better optics. And if the patient wants optics as well as comfort, then you can go for the hybrid lens. Hybrid lens have a rigid center and a soft skirt. The rigid center gives better visual acuity and the soft skirt gives comfort to the patient. Then you have the custom soft, that is a tailored design for early to moderate keratoconus when comfort is the primary concern. Piggyback also gives enhancement to the comfort for intermediate cones. This is a soft lens beneath an RGP. This is for patients who love optics but cannot tolerate the rigid gas permeable lenses. Of course, the scleral lenses are the first choice in advanced keratoconus in eccentric cones and also when there is lot of RGP intolerance, because it vault the entire cornea and gives superior comfort. So this is a quick visual summary of the modern lens designs. See, this RGP and rose scale lenses give a 3-point touch fitting, and the hybrid lenses, as I was saying, they have the rigid center and the soft skirt. Example are Synergize. Then you have the custom soft. The custom soft, as you can see in this picture, they have a thick optic. Thick optic can give like contour the cornea, give thicker optics can contour the cornea and give better optics, while the thin periphery can offer comfort. Piggybacking is still a valuable trick for comfort, and scleral lenses gives an unmatched comfort and stability for completely vaulting the cornea and creating a perfect optical surface. So every design has a role, and the skill lies in identifying which clinical scenario needs which lens. Science also has played a huge role. There are material advances like high decay materials which offer high oxygen permeability. There are asymmetric back surface which can confirm the cone, and also surface coating. So with these designs, we can now confidently offer all-day wear to most keratoconic patients without compromising the safety. The decay values as high as 200K is available. So this is an example. This table I have given due to the different brand names. The high decay materials brand names are Kerasoft IC, Boston XO, Synergize hybrid lenses and all. They have enhanced oxygen transmissibility and increased water content, so they can be worn as extended wear. The asymmetric or the cone specific back surface designs improves the cone conformity. Example are your Rosque 2 IC, again hybrid synergized lenses and all, and advanced surface coatings, the Hydra PEG. These are all available especially in scleral lenses to improve the wettability and to increase the comfort and reduces the deposition. Plasma treatment is available on Rosque lenses, the Boston gas permeable and most of the scleral lenses. So two breakthroughs are reshaping the contact lens fitting. These are wavefront guided optics and the 3D printing custom manufactured lenses. As you can see in this diagram, the wavefront guided techniques corrects the higher order aberrations like coma, trefoil and all, and it can improve the mesopic and the night vision, and this is primarily used in scleral designs. It measures the eye's optical fingerprint and then it is built, that correction is built into the lens, and they offer excellent rotation stability. So these are given in highly irregular corneas. The 3D printing and the custom manufacturing, they are also topography driven lenses. Scans of the patient's topo is taken, or the ocular surface, entire ocular surface has been scanned, and these are converted into a precise lens template. This means faster fitting, fewer trial lenses and much better comfort from day one, and this enhance precision and comfort to the patient. So these are some practical tips, some pearls from day-to-day practice. Do not hesitate to switch the lens category. If a patient cannot use an RGP lens, it doesn't mean that he should not be offered any other lens. He may be a perfect candidate for the scleral lens. And also, for all lenses, educating the patient about the care and expectations dramatically improve the compliance of the patient. Centration is everything in keratoconus fitting. A well-centered lens ensures stable optics, comfort, and reduces the mechanical stress on the cone. For scleral lenses, the optimal vault means there should be no corneal touch, no excessive clearance, and even distribution across the landing zone. And most importantly, the fit must respect the cornea. If there is epithelial insult, if there is apical scarring and all, it is a failed fit, and irrespective of the visual acuity. Even if the patient is having good vision, you should respect the cornea more. So concluding my talk, contact lenses continues to offer the best visual rehabilitation in keratoconus. With wavefront guided and 3D printed lenses, it redefined customization, and the future practice can be a precise, personalized and patient-centric vision. So I usually take up the patient for CXL only after a contact lens trial to determine the visual potential. If there is no improvement, visual acuity improvement with the contact lens, then there is no point in offering CXL and later on taking for keratoplasty and all. So contact lens is of course the cornerstone in keratoconus management. Thank you.
Thank you, ma'am. As madam rightly said, every keratoconus patient has to undergo a rigid contact lens trial, whether it is an RGP or scleral contact lens, because before deciding that they're amblyopic, it is very important. Again, to plan any kind of interventions for these patients, visual acuity, quality of vision is very important. No matter what we do, if you're not clearing their higher order aberrations, if you're not giving them good quality of vision, it doesn't serve the purpose. So always for every keratoconus patient, it's important to undergo a contact lens trial. So moving on, I'll be talking on CARES. Now this is one of the path-breaking treatment for keratoconus. Now patients we do contact lens trial for the patient, we give glasses for the patient, but some of them are not satisfied because of their job profile, nature of work. They are having good visual recovery following contact lenses, but they may not be ready to go ahead with it. So as in a brief way, the management of keratoconus, as my colleague already spoke, structural integrity we have to maintain or control with the help of C3R. So this is going to make sure that the collagen cross-linking is not going to progress. But that is not the end of it. We have to give them visual enhancement in form of glasses, contact lens, or there's a procedure called as Intax earlier. So, and if none of them is actually working for the patient, that is when we go in for a keratoplasty in such kind of keratoconus individuals. So in the early 2000s, we had the intracorneal ring segments. This was introduced in the market in an attempt to delay or prevent lamellar keratoplasty or penetrating keratoplasty. So this was basically a semicircular implant made up of biocompatible plastic PMMA. So this was causing flattening of the cornea, thus improving the quality of vision among patients. But over a period of time, we saw extrusion, migration, melt, infection of these segments, because of which there was a need for an introduction of a newer technology. So this is when emerged the procedure CARES, which is called as corneal allogenic ring segment. So this reduced the complications like extrusion, increased the biocompatibility compared to the synthetic intracorneal ring segments. So the technology was different, but the mechanism of action was still the same, and the principle was the same on which this was brought in. So Dr. Susan Jacob introduced this in the year of 2019. So in the CARES procedure, the principle being the same, instead of the plastic rings, we changed it into a donor corneal tissue strips, which was introduced intrastromally into the mid-peripheral recipient cornea. So this caused flattening of the cone in the center and thus improving the vision. So CARES basically looks at regularizing the cornea, and it's not a refractive procedure which is going to get rid of your glasses or contact lenses. It is only going to make your cornea more regular, because of which patient is going to have better quality of vision. It is based on the principle of Barakak's thickness law, where the central corneal flattening occurs when you increase the tissue in the periphery. So the main indication is keratoconus, where patient is looking for better quality of unaided vision. Patient is having poor recovery after contact lenses, they are intolerant to contact lenses, or they don't want to wear contact lenses, and patients post C3R. All of these patients we can definitely consider CARES, although there are some indications and contraindications. Pellucid marginal degeneration and post-LASIK ectasia are some of the other indications. Now, pre-operative planning is very important. Firstly, we need to take the pentacam of the patient. If the pentacam is less than 250 micron thickness, then definitely keratoplasty is the go-to option for these patients. And cone, any kind of an advanced cone also can be considered. Even the nipple cones can be considered for CARES procedure. So cone is not a major criteria. Anterior segment OCT has to be done to make sure that there is no scarring, because if the scarring has already set in, there can be no flattening that is going to occur after this procedure. And definitely specular microscopy to rule out any kind of fugues or endothelial decompensation. So once this is done, this is how the procedure is actually performed. So you take the donor cornea and remove the endothelium of the donor cornea. So we can use any grade of cornea as long as the peripheral is clear and there is no scarring. So this is a double bladed Jacob's trifine. So it has an inner ring and an outer ring of 2 different diameters. So the trifine is basically punched. So you get a 6.5 inner or a 7 outer, or a 7 with a 8 outer ring. So once this is done, the outer ring has actually full thickness up to the Bowman's membrane, whereas the outer ring has just stroma or a thinner segment. So this is cut open and extended. When you flatten, you can see that there is a part which is very thicker and there is a part which is thinner. Now this is placed on a dome-shaped customizer, again which is clearly designed for keratoconus CARES patients. So this ring has from 3 mm to 12 mm zone. So you would have done a pre-operative planning for the patient as to where you want to place the segment. Same thing is mimicked over here, and the segments are marked. So this is not a very big rocket science. Once you have planned pre-operatively, this is going to be very, very simple. So once these markings are done, the segment is cut accordingly as much as required. So this can be shaped, it can be kept in a normal thing. And after this, you need to place it on the Teflon and see whether it is matching your plan, what is previously done. So as you can see, this is the inner part which is thicker, having the Bowman's membrane, and the thinner part which is a stroma. The channel can be manually created or with the femtolastic channel can be created. Then in the host cornea, the same channels are marked before inserting the KSOS ring. You can use the Y hook, which is specially designed for this, to create the channel and open up the channel. Once this is done, carefully the segment has to be placed, again making sure that the blue marked Bowman's member is on the inner side and the thinner stroma is on the outer side. So initially it will be a dried segment. While inserting, we have to put a lubricant on it or saline on it so that it's more smoother while inserting. And it's a very easy procedure. Once this is inserted, the pre-operative planning is done perfectly, then it is not a rocket science to do this procedure. As you can see in this photo, there is a significant flattening or regularization of cornea following the KSOS procedure. So what happens, what are the benefits of this is that the KSOS actually is placed on the mid-peripheral position and it prevents limbus vascularization or the central visual axis damage. It is patient's own cornea is preserved. We are not going in for a keratoplasty. The periphery, we are adding extra donor tissue again, which is very biocompatible, and this increases the thickness because in keratoconus it is the thinning of cornea which is the major problem happening over here. So we can see that clinically when we are doing a pentacam, we can see that there is increase in the betterment of spherical equivalent, topographical astigmatism, maximum and steepest keratometric value, all these we can see. But from the patient perspective, even though the refraction may be different, their unaided quality of vision is much better. A patient with 6/60 CF vision, when we are doing KSOS in them, they reach almost up to 6/18. So their glass-free vision also is much better, following which they are more acceptable for contact lenses or glasses. So some of the main benefits of over DALK is that in DALK we have sutures, so suture related complications, chances of rejection is prevented, surface dryness, surface issues are again prevented, and last but the worst option is when you are doing a DALK procedure, if there is a perforation, now in these young patients at a very early age you are going for a full thickness keratoplasty. So all these complications are actually avoided by doing KSOS procedure. Now KSOS also is a surgery, but it's a faster surgery. Patients are having better quality of vision. It is reversible. So tomorrow if you feel that this patient's cone is now, you're not actually placed the segment in a proper manner, the channel is already there. So you can redesign, recheck about the planning and then do it on the patient. And it's an early treatment making them contact lens compatible. Now, some of the advances that are happening in KSOS is, as I told, over a period of time, people started customizing the KSOS segment. So, depending on the cone, depending on the nature of the steepness, superior, inferior, the design of the cone, you can have multiple ways in which you can design these KSOS segment. So, that is a very important thing. As you can see here, the cone, this is actually a very customized cone to make sure that the periphery is flattened and the central superior inferior is not flattened. So these are the main things which are important in case of a KSOS procedure. Thank you so much. Now, as I mentioned, once there is scarring, we will not be able to do any kind of KSOS or intact procedure. That is when deep anterior lamellar keratoplasty or penetrating keratoplasty comes into picture. So we have our colleague Dr. Hilda who will be talking about keratoplasty in keratoconus.
Good morning all, and thank you Sanjana for this opportunity. Keratoconus was first described in 1736 and Pickford had then told its intractable nature and fatal to vision. The pathology and treatment are so little understood. Around 289 years later, keratoconus still remains as an enigmatic disease. With the prevalence what we have, keratoconus, even in the British Journal in 2012 was told, was one of the most common indication for keratoplasty. In a span of 2 decades, there's a big paradigmic shift which has occurred, and no more keratoconus is the first indication for keratoplasty. And the decreasing trend is mainly because of early detection of diseases, routine eye screening by optometrists and ophthalmologists in the community, good control of ocular allergy, implementation of collagen cross-linking. With all these you have in hand, the risk of disease progression is reduced, and also the chance of acute eye drops is reduced. And we have n number of CXL procedures, and Sanjana also explained about KSOS. And when you have all that, keratoplasty come last in hand and in your thoughts. And you think this is the end, but still you have gene therapy taking over, gene targeting keratoconus and halting the disease progression. And once gene therapy has taken over, no more Keratoconus will be an indication for keratoplasty. So all the matters what we see today are the present, and very soon it's going to be in the past once gene therapy takes over. In spite of all the modalities, we have 20% of our patients will end up in keratoplasty as reviewed in journal 2023. However, the disease often affects the eyes asymmetrically. Many affected individuals remain asymptomatic until one eye is significantly affected. That is, most of our patients who come to us can be saved with CXL in one eye, but other eye would have gone for eye drops or scarring and will end up in keratoplasty. Very rarely you have both eyes going to keratoplasty nowadays. The king and queens of surgery are KP and DALC. Starting with KP, the indication will be full thickness corneal scarring, acute eye drops and perforation, extremely thin corneas. You have legends here operating on thin corneas, but when it is less than 150 and 200, it's quite difficult to do DALC. And when you have coexisting endothelial dysfunction. KP has very high success rate in keratoconus. The Australian study has shown 89% success rate in 10 years and 49% in 20 years. This is a keratoplasty I had done in 2023 in right eye with BCVA maintained well, and in the left eye post C3R. This photo, the keratoplasty was done at Little Flower 40 years back, and recently I had done phaco in the patient. I just put this photo to show how good the graft survives in spite of 40 years. It's very easy to identify olden keratoplasty because the grafts are pretty small those days. In spite of good results, we do have failures because of relatively younger age and greater lifetime. So you have greater chance of rejection and repeat grafts. The biggest villain which I face, I think most of them face, is glaucoma. The incidence of glaucoma is 9 to 35% post-keratoplasty. The one problem is it's difficult to measure IOP in the early stage because of irregular Myers, and even your disc changes may not be assessed. I would like to share one of the case. A 15-year-old boy had come to me with keratoconus both eyes, with left eye followed by eye drops and dense scar. Right eye I had done C3R in 2021, and 2022 I had done KP. Patient was doing fine for quite some time, but he came back to me after his annual exams and during vacation. By then his IOP had spiked very high and CDR also had changed. The problem with young kids and young adults, the disc changes occurs much faster than adults. The problem with glaucoma, when it starts appearing, when you start to interact it with anti-glaucomas, they do respond. But if your IOP is high for quite some time, they become very, very stubborn and hardly they respond to the anti-glaucoma medication, and they'll end up in TRAB. So with glaucoma department, had done TRAB in 2024, and patient had developed PSC, I had done phaco in 2025. These are his fields, and you can see the peripheral fields are lost, and he has only tunnel vision. This is a photo of that patient. You can see supranasally well-looking bleb, beautiful graft, and IOL there. Vision, BCVA is maintained 612, but I'm very sure it's tunnel vision. The other problem we face with keratoplasty is post-keratoplasty astigmatism. The Australian study has shown 61% of the patients have to depend on spectacles and contact lenses after keratoplasty, out of which 77 patients had more than 5 diopters of astigmatism. The recurrence of ectasia is another problem, where you have anatomically clear graft but functionally not useful. You have recurrence most commonly as seen at graft host junction, around 10 to 30% in 10 to 20 years. This is a photo of keratoplasty done at LF 27 years back in right and 35 years back in left. You can see here I have similar ectasia which is occurring in both eyes. Patient has developed cataract, was planning cataract surgery and IOL later, with scleral contact lens later. The other cause of failure will be infected graft and failed graft. Coming to DALC, I'm not going to the procedure. As we all know, we have pre-response layer, Duvas layer exposure with big bubble and viscoelastics and fluids, and you have a manual dissection too. The surgery of choice is DALC always when your endothelium is clear and free of scarring. All the indication for KP will be a contraindication for DALC. If you ask which is better, there is no doubt DALC is always superior than KP because it eliminates the endothelial problems of rejections and failure, lower risk of endophthalmitis, reduce the risk of complications, reduce the dependency of steroids, and hence reduce the glaucoma occurrence, faster recovery, good graft host junction, and a potential pool of donors increased because we are not even taking endothelium into consideration in this case. So you have more of donors. Friends study have shown 3 times survival rate of DALC than KP, and it's a DALC done by Lailand, but when she was at LF, patient is under my follow-up now. 2014 and 19, BCVA maintained well. I put this photo mainly because the patient was steroid responder the right first week after keratoplasty, but still the patient survived, and the graft survived with fluoromethalone and cyclosporin. Among the procedures of DALC, big bubble always stands superior than manual dissection in quality of vision and also the reduced aberrations, because in manual dissection you have irregularities on the graft source junction and even in the interface and can cause undesirable vision. DALC has a steep learning curve and surgeon dependent. Retrospective study also have shown the chance of perforations 45.4 and 24.1, and all this can be overcome when you have an intraoperative imaging and also femtosecond assisted. The graft house interface is one extra thing which you have in DALC which is not there in KP. It can cause irregular blood vessels, inflammatory debris, and also suture-related infections. Whatever said, it can never override the advantage of DALC. Now, if the patient comes to you, what do you do next? For a case, a 46-year-old patient had come with keratoconus and C3 are done both eyes. You can see the vision is counting fingers 2 meters and 1 meter with very high cylinders in both eyes. This is the pentacam results of right eye and as well as left eye. So before you jump into keratoplasty, the one thing which should cross your mind is the patient amblyopia, because you don't know the patient was not wearing glasses and spectacles or contact lens for a very long time and you don't know when the keratoconus has occurred. So hang on, before you go for keratoplasty, do a scleral contact lens. When you put scleral contact lens, you have two things happening. One, if the patient is not improving vision, you can always explain to the patient after keratoplasty, this might be the vision you're going to get and the patient is amblyopia. If the patient is improving vision, you can buy time and get away with scleral contact lens itself. And also it gives an idea and anticipation what will be the vision if you do a KP in this patient. So scleral contact lens was given for both eyes. You can see 6/9 improved in both eyes and patient is not amblyopic. Other example, patient had come following high drops and dense scarring. This is the pentacam results of right eye and left eye. You can see both eyes keratoconus. Left eye I could get away with CXL and glasses. Right eye has advanced keratoconus with scarring, so scleral contact lens was advised. Patient had improved to 6/9. 1 year later, patient developed scleral contact lens induced infection with serratia emerescens, but improved with moxifloxacin and tobramycin. Now, what is your next plan? Patient after the infection is not willing to use contact lens. Patient wants a surgical treatment. So in that case, do your ASOCT, see the depth of scar and intensity of scar. If scar is very deep and DALC chance of perforation is high, in those cases KP will be better. The last example, a 42-year-old patient had come with 6/9 vision and 6/18. You can see the patient has cylindrical value more in left eye. And this is a slit lamp examination. And when you see slit lamp, when you focus on the endothelium, there are some gutties and vacuoles. So these are the pentacam results of right eye and left eye, showing keratoconus slightly in more of left eye. And these are the specular analysis. The genetic analysis of keratoconus as well as Fuchs endothelial dystrophy are two different patterns and it's very rare to occur. But I've seen around 5 to 6 cases with keratoconus with Fuchs as well as with posterior polymorphous dystrophy. So it's very important to check your endothelium before you plan a DALC. There are articles which has published keratoconus with Fuchs in 2021. Even in Kerala Journal of Ophthalmology, our own journal in last year, 2024, have shown the genetic connections with keratoconus and Fuchs, where identical twin was analyzed with gene mutation of ZEB1. So it's important to know both, because in these two, it can mask each other's. If your endothelium is slightly deranged, it can also change your pentacam results. So things which are steeper may not be steep. So conclusion, always think of keratoplasty last in your mind when you have all the modalities possible. DALC always stands superior for KP. In case you have any doubt, you can always plan DALC bar KP. That is, you plan for DALC. In case you go for perforation, keep your KP ready. Speak to the patient, understand the patient need, and customized treatment will be the best choice for the patient. Thank you.
Thank you very much. So that's an excellent talk on keratoplasty. Now we have the most glamorous talk, that's refractive surgeries in keratoconus. Lot of times as refractive surgeons, we end up diagnosing keratoconus when patients come for refractive surgery. So there's always a dilemma. Do we go in for a disease perspective and don't give them a visual rehabilitation with glass-free options? Or do we go in for a refractive surgery? So over to you, Ashwati.
Thank you, Sanjana. So I'll be talking about the refractive correction in keratoconus. The two main concerns in keratoconus is the progression and the visual rehabilitation. The progression is taken care of by C3R as told earlier, and I'll be talking about the visual rehabilitation. Why the topo-guided ablation? Because it improves the asphericity of cornea, improves the refractive outcome, that is quality of the vision better than the quantity, and better tolerance to the contact lens or glasses. We have various protocols like Athens, Cretans and Cretan Plus. The most popular one is the Athens protocol, which we follow. It is a topography guided partial PRK combined with the CXL. In this, unlike the routine LASIK that we do for 6.3 mm optic zone, here we take only 5.5 mm optic zone. And we do not correct the full refractive error. That is, we correct only the 50 to 70% cylinder or spherical correction. and ablation of stroma should be less than 50 microns, and we do only for the thinnest Pachy above 450 microns. The CXL is always accelerated CXL. The other protocols are the Cretin and the Cretin Plus protocol. In Cretin protocol, we do the PTK with CXL. PTK in the sense that it uses the excimer laser to remove the epithelium. The epithelium over the cone will be thin. So while removing, we take a little part of stroma also. And the other one is the Cretin Plus, which is PTK plus PRK plus C3R. Both have good long-term results. So coming to the topography based custom ablation treatment, that is the TCAT. The most popular no financial interest is the wave light in Alcon, and Schwinn platform we have the corneal wavefront mode. This is for the selective cases for the mild to moderate keratoconus with the thinnest Pachy more than 450 micron, poor contact lens fit or unhappy patient with the glasses, and there should not be active ocular inflammation or central scarring. So this is a picture from this scan from the serous topography. The anterior curvature tangential, we can see there is a central cone and thickness is more, that is 514. So this is a best candidate to have a refractive correction if there is cylinder. And in TCAT, in the center cone, we can ablate, the center cone will be the steeper area and the area superior to it will be flattened. So the aim of us is to regularize the cornea, that is flatten the steeper area and steepen the flatter area. For that, we'll have two ablation area, that is at the center cone and the mid periphery, so that the central area between the both will be flattened here and here. So the area in between both will be steepened and the cornea will be more regular. So automatically the refraction will be more corrected. So TCAT gives us partial refractive correction. So while counseling, never counsel that we can completely avoid the glasses. Tell them quality of vision will be better and we will have refractive correction on regularizing the cornea. Saying about the quality of the vision, this will be the what the patient see before the correction, and after the correction it will be more clearer by reducing the higher order aberrations. Always the simultaneous C3R is better than the sequential C3R because there will be less post-op haze, more predictable refractive results of visual outcome due to ablation of the normal non-cross-linked tissue and less post-surgical recovery period. I'm just showing the calculation chart in Schwinn. This is a patient who had -4 cylinder. And the treatment modality, we are taking it as a corneal wavefront mode. And patient had -4 cylinder, so I am correcting only 2.5 cylinder. The patient had a Pachy of 508, so it was safe. And I ablated only 26 micron stroma. This is the epithelial thickness, stroma only 26. The residual stromal thickness was 427. So patient improved to plano 6.9 with eliminating -4 cylinder. What if thin cornea and a descended cone? What I talked about the TCAT, better results are with the central cones. If it is a thin cornea and a descended cone, we have the TREC in place, that is topography based customized cone ablation of keratoconus with PRK with C3R. This is done in Schwinn platform since we can descend the point, pupil center. This was first discovered by Dr. Rohit Shetty from Narayan Netralaya. TREC is also done in the Schwinn Amaris in the PTK cam mode. This is for descended cone, thin cornea, and here the beauty is that we take only 20 micron depth of the cone and we calculate the cone area with the optic zone of only 3 to 4 mm of the apex. So we take only very little stroma, still have a great correction. Example, this is a cirrus topography scan. This is the cone area. So we measure the cone. This is the long axis. Then we'll measure the short axis and offset radius. That is how much the radius is shifted from the center. The center radius is shifted from the center. We measure that and we put in our calculation sheet. This is the long axis, short axis, how much depth, and we can see how beautifully it coincides with the picture we made. This is the measured one in the Schwind, and we'll ablate this area only, this cone area of 3 to 4 mm only. So this is a picture. I have done the epithelial remover by the instrument, and we descend the pupil axis and we ablate only this area, that is cone area that we have calculated. That area is only ablated. See, this area is only ablated, unlike the 5.5 or 6.3 optic zone. And this is followed by the accelerated C3R. So I'll be discussing about few cases. This was one case. So you can see the thickness was only 431, and we have a descended cone here. I measured it and did track. The pre-op vision unaided was 618. It corrected to plano 66. We cannot predict the outcome, but we can assure the patient that the better quality will be there, and on regularizing the cornea, we'll have a better vision. It's 2 weeks post-op, thickness is still 412. This is second case. It's also, we have a descended cone. I ablated only that cone area. Unaided pre-op vision was 618 parts, and this much cylinder and sphere she had 69, and it corrected to plano 69 unaided. This is the case 3, the same picture. She had 660 with she could not, no correction with any sphere or cylinder, and post-op she had 4-line improvement. So patient was happy. Second is the TCAT cases. It's little more central cone and thickness was 460. Unaided vision was 618. With this much cylinder and sphere, it was coming to 612. Post-op, it came to plano 69. This is also a similar case. Central cone and thickness was 512. So I safely did TCAT, and pre-op vision was 636 unaided. And unaided it came to 69. With correction, it came to 66. With 0.75 cylinder only. And this is the case I showed last time. It was a -4 cylinder for the patient. I corrected and it came to unaided plano. So the take-home messages are: TCAT is suitable for the central cone and thicker cornea. TREC is for the eccentric thin cornea. Final corneal thickness should be above 450 microns with the epithelium. Both are followed by C3R, and these both regularize the cornea, correct the refraction, and have better contact lens fitting. Thank you.
Thank you so much. So as we are coming to the end of our session, I would like to again summarize that keratoconus is no longer a disease where you stop it with a C3R and leave the patient with whatever vision they are having with glasses. You have to look for the maximum visual benefits that you can give for the patient. It could be with the simple contact lenses. The problem with contact lenses is patient have to wear it every day and remove. Sometimes it becomes difficult. For that, we have certain refractive procedures like TREC and TCAT. We also have corneal remodeling procedures like CARES. Now, both these procedures are aiming in regularizing the cornea. So, both of them try to make the irregular corneas into a regularized cornea so that their compatibility with glasses or contact lenses increases. Now, those patients who come at a very late stage where the cornea is already damaged, significant thinning has occurred, that is when we would go in for a keratoplasty like a DALC or a penetrating keratoplasty. So whenever you get a patient with keratoconus, always explain to them that you have options for improvement of vision. There are different ways in which they can get to see better. because these are all young patients. So they range between the age of 20 years to 30 years. So they are all into social media, they're all into active lifestyle, they are traveling, or whether it is social, Instagram, Facebook. So the quality of vision is very important. So this is the age when their career is also going to be building. So that is why it is very important to try and see, whenever you get a keratoconus patient, you have to see how you can visually rehabilitate them along with controlling the disease. Thank you so much.
The audience are having any question, they are most welcome. I have a question to Ashwati. Do you find any increased haze? Okay. You do accelerated only, no, after TCAT? Because I find one or two patients increased haze, and whatever I did was from Rani Menon's hospital, and I lost follow-up. I think Shobha might be doing more now, no? Topo guided PRK. So what is your experience? Mike, here.
Actually, haze is a problem, so I don't touch the severe cases nowadays. If it's mild, it's okay. The results are very good. Visual acuity is improving. Patients are really happy. That is a good part of doing TCAT. But the case selection is very important.
Exactly as ma'am said, the case selection is very important because we have to see the age group of the patient, especially females, their childbearing age, or male patients. We can go for a younger age compared to female patients. And most important thing is follow-up. Following the procedures, most of them are lost to follow-up, and they come back when vision would have been lost, or we wouldn't able to control it. So that is why after every kind of a refractive procedure, it's important to follow up these kind of patients so that we tell them that if there is a problem, we can control the disease.
Pediatric age group.
Pediatric age group, ma'am, control of the disease is important. So at least after 15 years, definitely, because we'll be doing an add-on C3R for these patients. So after 15 years, it is okay to go ahead with the cares for the patient. So there is no age limit for the cares procedure. In care, steroid is used at least for a month or two. That's it, ma'am. Not more than, like a typical kerato with C3R patient, maximum 1 month or 2 months steroid is used for the patient.
Do we have customized here now?
No, I right now it's
This
been
Jacob,
mainly done
Susan doing?
Yes, Susan ma'am is doing customized cares.
No, is it automatic like in US and all? Now they are
No, it
giving
is a
it like
handmade.
that.
It is a
Handmade only.
customization which is done depending on the cone. Madam decides what type of design is required, where the flattening, where the steepening. According to that, she would customize. So I had shown in my slide.
Yeah,
Actually,
yeah, I saw
there
that.
are various
I
customizations.
want
Which are
another
possible.
one quick thing is do you insert it dry or
It is to be
slightly
inserted dry. The moment you insert it, it
insert
has to
it
be
just
hydrated so that then the entry becomes more smoother.
more smooth? Okay, thank you.
Thank you.